Well, welcome. On behalf of ICS, Therese, Rinku, and I would like to thank you very much for participating in this workshop on statistical methods for assessing the effect of the pandemic on use of health services. This workshop is comprised of 3 separate components. I will begin and present one possible statistical approach to address those questions. I will be followed by Rinku and then by Therese, who will each present a different approach to modeling the effect of the pandemic on health services use in Ontario. My component of the talk is called a Poisson regression-based approach, in which we use a series of Poisson models to model the effect of the pandemic on the change in the rate of health service use in Ontario. So if we were to examine the use of health services over time, that the effect of the pandemic would often look something like one of these 3 lines here. That prior to the pandemic, so in the weeks or months prior to the pandemic, the rate of health service use, whether it's emergency department visits, whether it's physician visits, surgical procedures, diagnostic tests, and so on, tend to be in a steady state. There may be some bouncing around, a bit of noise, but on the whole, we would see a steady state trend. And then once early mid-March hits, the rates of health service use drop off a cliff, and there's a precipitous drop in the use of services. Then, in studies that look at the early pandemic effect, there's never a recovery. Whereas for studies with a longer time frame, there's one of 2 possibilities. Either there's a gradual recovery and the use of health services eventually attains its pre-pandemic level, or there's a gradual increase, but the rate of health service use never recovers to its pre-pandemic level, such as in the blue curve here. Once one has a plot like this, the question often becomes, well, in order to publish this, I need to get a p-value. I need to show that this trend is real. And so the question naturally arises to the clinical investigator, how can I put a p-value on this figure? Because that's what will allow me to get it published. So when I was thinking about that question, I thought about this article, which is one of my favorite articles. It's called The Religion of Statistics as Practiced in Medical Journals. This was published in the American Statistician in 1985. And I just want to read parts of this commentary written by a biostatistician who worked for much of his career in clinical research. So if we look at the paragraph in yellow, he says, I find the religion itself a fascinating study. And by religion, he means the religion of statistics. The practitioner engages in a ritual known as hunting for p-values. And then if we continue, to the physician who practices this religion, statistics refers to the seeking out and interpretation of p-values. Like any good religion, it involves vague mysteries capable of contradictory and irrational interpretation. It has a priesthood and a class of mendicant friars. As an aside, I think that means myself, Therese, and Rinku. And it provides salvation. Proper invocation of the religious dogmas of statistics will result in publications in prestigious journals. This form of salvation yields fruit in this world, increases in salary, prestige, invitations to speak at meetings, and beyond this life, continual references in the citation indices. So, tucking that away in the back of our minds, we now return to these common scenarios where we see a relatively steady state in terms of use of health services, and then a dropping off, a precipitous dropping off of use, and then either a gradual recovery or no recovery at all. And we ask, how can we model the effect of the pandemic on the use of health services? Now, there's problems with using conventional statistical models for modeling the temporal trends during the pandemic. First, as shown in the previous graph, for many types of health services, there was an initial precipitous drop in the use of health services. Secondly, the rate of use of health services could change weekly during the pandemic, depending on the different levels of openness, depending upon provincial regulations, and what was allowed, we could see dramatic fluctuations week by week or month by month during the course of the pandemic. Thirdly, depending on the timeline and setting, a dramatic initial drop could be followed by a gradual increase in the rate of health services use. And finally, many of these observed patterns do not have simple parametric relationships with calendar time. If we were to go back to these figures here, in particular the purple and the blue one, where we see a gradual recovery, it's very difficult to describe a parametric relationship with time that follows these shapes here. I'm now going to illustrate the methods I'm going to describe using data that is courtesy of David Gomez, who is a surgeon at Unity Health in downtown Toronto. So this is from a publication in the British Journal of Surgery, in which they examined the rate of surgical procedures performed in Ontario before and after the pandemic. This graph shows the weekly rate of surgery per 100,000 person weeks in 2019 and 2020. Each point on the graph is a weekly rate of surgery, and we can see by comparing the red dashed line to the blue solid line, we can compare the rate of surgery in a given week in 2020 with a corresponding week in 2019. Two vertical lines are superimposed on this figure. The leftmost one is March 15th, when Ontario hospitals were asked to ramp down elective procedures. This was followed 4 days later by March 19th, when there was a directive issued mandating cessation of all non-essential and elective surgeries. What we see is that in the weeks prior to the pandemic, the rate of health service use in 2020 were essentially identical to those observed in the previous year. In the first week of the pandemic, we see a rapid decrease. However, this mirrored what happened in 2019. The only message we can take home from this is that surgeons go on March break, since the first week of the pandemic coincided with March break, and we saw a reduction both that corresponded to that which was observed in the previous year's March break. However, in the second and third week of the pandemic, we see a precipitous decline in the rate of surgery in Ontario compared to what was observed in 2019. So one way to analyze these data is through using a series of Poisson models, where the primary analysis uses a Poisson model to compare the rate of surgery in each week of the pandemic with the corresponding week in the previous year. So we would fit a series of univariate Poisson models, one for each of the pandemic weeks, in which we would compare that week to the week to the rate of health service use in the previous year, in the corresponding week in the previous year. We can then use the time in 2020 prior to the pandemic as a negative control analysis, where we repeat the above analysis, comparing each week in 2020 prior to the pandemic to the corresponding week in 2019 to assess for secular trends and to serve as a negative control. This would describe the simple univariate Poisson model that one could use, where the count of the number of surgical procedures in a given week is regressed on an offset variable denoting the population size. This is simply the at-risk population. This is the number of people who are at risk for the given intervention. So when modeling the surgical rate, it's simply the size of the population who would be eligible for surgery, or in this case, the entire Ontario population. In different clinical contexts, the size of the population at risk or eligible for the service or intervention or procedure may be smaller than the Ontario population. But essentially, one uses an offset so that we're modeling rates rather than strict counts, and then we have a fixed effect or a variable for denoting year. If we exponentiate beta, which is the regression coefficient for a year, we obtain a rate ratio comparing the relative change in the rate of the outcome between 2019 and 2020. And we can use model-based confidence intervals to obtain a confidence interval for the rate ratio. So how would this work in David Gomez's study? So we return to the same graph as before, which is now being modified with a vertical arrow denoting each of the weeks. We have black arrows for the weeks prior to the pandemic, and we have 3 red arrows for the weeks during the pandemic. At the location of each arrow, we would fit a Poisson regression model comparing the rate of surgical procedures in 2020 in that week with the rate of surgical procedures in the corresponding week in 2019. So we have these results. During the first week of the pandemic, the rate ratio was essentially 1, with confidence intervals that included the null. This indicates that there was no change in the rate of surgery compared to the same week in the previous year. This is primarily a reflection of the fact that the first week of the pandemic occurred during March break, as I alluded to before. During the second week of the pandemic, the rate ratio was 0.22, denoting a 78% decrease in the rate of surgery compared to that which was observed in the same week in the previous year. In week 3 of the pandemic, the rate ratio was 0.17, denoting an 83% decline in the rate of surgery compared to the same week in the previous year. Then when we turn to the control periods, so the weeks prior to the pandemic in 2020, we see that weekly rates of surgery did not differ in 2020 compared to the corresponding week in 2019. While this reflects what was done in that study, there are possible modifications that one could use. One could choose to use multiple years prior to 2020 to estimate the baseline rate of health services use. One could possibly, by using a wider range of years to establish the baseline, one could remove a bit of the noisiness, the potential noisiness in the baseline rate. Rather than reporting overall counts and overall population size as an offset, one could have counts and population size within age sex strata and fit a Poisson model that adjusted for age and sex in the Poisson model. I would guess that this is generally not necessary, as in most settings, the age sex structure of the population probably does not change meaningfully over a 1-year period. What are some advantages or strengths to this method? First, it's conceptually simple. Second, it does not require a long history prior to the pandemic to model secular trends and then project forward. Thirdly, it allows for a week-by-week examination of the effect of the pandemic on health services use. And fourthly, it avoids parametric assumptions about the relationship between time and the rate of health services use. So if we think back to those initial figures I showed, that in many settings, it could be difficult, excuse me, it could be difficult to come up with a parametric model that adequately describes this relationship over time. Fitting a series of weekly Poisson models avoids the need to do this. However, this method is not without its limitations. With a longer observation window during the pandemic, this method produces a large number of rate ratios. For each week or each month after the pandemic, we would have a corresponding rate ratio. Now, we can partially circumvent this problem by providing summary statistics of the estimated weekly rate ratios. If David's study had been extended for 15 or 20 weeks, we could have reported a range of rate ratios and said that the rate ratios fell between X and Y, and that they were all statistically significant, or they all had confidence intervals that excluded the null value. A second limitation is that the Poisson model makes a rather strong assumption that the mean and the variance of the random variable are equal, whereas in practice we may observe overdispersion in the rates, leading to a violation of the Poisson assumption. There are two possibilities to address the violation of this assumption, and one is that we can modify the Poisson model to explicitly model the overdispersion parameter by using a quasi-Poisson model that explicitly models the overdispersion parameter. A second option, which is probably the more common of these two secondary options, would be to use a negative binomial model that relaxes the Poisson assumption. If we return, in conclusion, if we return to the problem with p-values in these studies, and so I framed the initial problem saying, well, we have this beautiful picture showing this rapid drop-off in rates, and that no one looking at those figures would say that there wasn't something there. And yet we often want to provide a p-value in order so that these figures can be published. However, there's a problem with reporting p-values in this study. And that is, how do we interpret the p-value from such a study? Well, to do so, we have to think about how the p-value is defined. In this case here, the p-value would be defined as given an arbitrarily large number of pandemics occurring under identical circumstances, such that in reality, none of these pandemics had an effect on health services use, in what proportion of these pandemics would one see a change in health services use at least as large as the one observed in the current pandemic? Now, I don't know about you, and I don't know most of you, but I think I can safely say that for most of us, if not all of us, that we would not want to see an arbitrarily large number of pandemics occurring under identical circumstances, that one is enough. And so probably we would not want to have a p-value that we could interpret, would then have to interpret. So that concludes the first proportion, the first component of today's workshop on using a sequence of Poisson models to evaluate or to describe the relative change in rates of health service use over time in the weeks during the pandemic to weeks prior to the year prior to the pandemic. Just in terms of formality, we have at the beginning of today's session, we've decided that we will delay questions until the end. So my talk will now be followed by Rinku's and then Therese's, and then we will take questions afterwards. Thank you very much.
Good morning, everyone. I hope you can hear me and see my screen. All right, no objections, so I'm going to proceed. Thanks, Peter, for that. So my name is Rinku. I'm a biostatistician and scientist. I'm here at ICS, and this work is in collaboration with Dr. Tony Iskander and Ching Li. So I'm going to be going over an overview, essentially, of 3 different methods that we have used and are currently using to assess the impact of the pandemic on health service use. The first one is segmented regression approaches. Second is a funnel plot approach. And the third one is a mean cumulative function approach. So I'll get right into it. For the segmented regression methods, they're often used to examine trends in an outcome over time. And they can be particularly informative when we have a priori cut points in the timeline in mind, such as a pandemic when it starts. Could also be, for example, when an intervention is introduced or when a policy has changed. So when we have a particular break in the time point we're interested in examining, this can be a very useful method. So segmented simply implies piecewise components. So it's not that you're stratifying your data into pieces, but you're using your whole data to find inflection points and to find changes in slope and intercept based on those pieces. So the term segmented regression is really an umbrella term. You can choose various specific types of regression models under the segmented regression approach. So for example, if you have a continuous outcome, you might think of using segmented linear regression. If you have a count or a rate outcome, you could think of using segmented Poisson regression or segmented negative binomial regression if there's a lot of overdispersion. Now, there are various ways to parameterize these models. And what I mean by that is how you actually set up the interpretation of the beta coefficients in your model. And that should really be based on what objectives you're trying to answer. So for example, are you interested in the absolute intercept of volume, let's say, of surgery, or are you interested in the change? So based on what you're trying to answer, that's probably how your model should be parameterized. I'm going to go right into our study example. This study has been published by JAMA Open, and we use segmented regression to actually examine our particular aim. So our objective was to quantify the impact of the pandemic on the volume of cancer-directed surgeries among individuals in Ontario. Excuse me. So the approach was to obtain weekly volume of all individuals in Ontario undergoing cancer-directed surgeries. We had to use CAI DAD and CAI SDS. So DAD is providing hospital admissions, SDS is same-day surgery. We actually did not have access to updated OCR at the time of this because things are happening so quickly. So that was one, not limitation I would say, but one of the challenges was to actually identify cancer-directed surgeries. But again, we did that using DAD and SDS, and the time frame was between Jan 1st, 2018 to June 30th, 2020. And so we gave ourselves quite a bit of room in the past to actually pick up on the overall trend prior to the pandemic. Now, we use segmented regression because we are looking at volume, so the number of cancer-directed surgeries, that's a count. So you can think of that using Poisson models or negative binomial models. We use both here. And I'm going to illustrate two different ways you could do this. We used one cut point. That's option A. So the cut point was chosen at the pandemic shutdown on March 15, 2020. So one cut point would mean two different segments. And then we also use two cut points. So the shutdown on March 15, 2020, and then around May 17, when the elective surgeries resumed again. So that was another cut point. So we wanted to see what happened in those three segments of time. So here are the results. Excuse me, my throat is scratchy for some reason. So here we are looking at volume as a function of weeks. So the x-axis is weeks, and the y-axis is the estimated number of surgeries. The actual dots represent the observed values that we saw, and the overlaid regression lines represent what was estimated using a negative binomial regression and using a Poisson regression, because we use both approaches. So let's interpret this. We see, based on the table on the right-hand side, I hope you can see my cursor. So you see that the estimated mean surgery volume just at the beginning is about 4323. So 4,323 surgeries are being done. And that's the mean starting at that week. Now, this is kind of zoomed in. And what you see from there on, you see this there's really no increase. That's at 1.0006. So this is a relative rate. This is telling us that the increased mean number of surgeries per week that goes by until March 15. So this is this first line. But as you can see by the confidence interval, it overlaps 1, not to mention the magnitude is essentially 1. So really there is a pretty consistent volume trend over time. And then all of a sudden, March 15, the pandemic starts, and here is where we can quantify the drop. You see a drop in the average mean volume all the way down to about 1482, so 1,482 procedures. So this is about a 65% drop immediately. And then the way we modeled it was to try to understand what happens every week after that. And then every week after that, you're seeing about, on average, a 6% increase in the estimated mean volume compared to the previous week. And this increase does not overlap 1, so we would say it's potentially statistically significant. So that's kind of the interpretation of this. Now, we also did this with 3 pieces, like I mentioned. And if we show you that, here's what this looks like. And so the reason for doing it in 3 pieces is to understand what happens during that middle time period. So between March 15 and May 17, where things were closed for elective surgeries. So same kind of trend in the beginning, same intercept. And same slope, so it's essentially constant. Again, this is zoomed in, which is why it looks like it's increasing, but it's at 1.0006 again. And then you see this huge drop to 1746 at the very beginning of the pandemic. And then this relative rate of 1.012, this is telling you that every week that goes by, there's a 1% increase. But again, this overlaps 1. So there's pretty much no movement during this period, which makes sense. And then once things opened up, you see that the mean volume, it slightly increased to 1943. And then after that, you see this 14% increase, this 11% increase week by week. and this increase does not, the confidence interval does not overlap 1. So this kind of gives you an overall picture of, what happened before, going back quite a bit to 2018, what happens right at the start of the pandemic, what happens during, and what happens when things opened up again. So that's why we presented the model in this way for this particular paper. We just found it easy to interpret. So that is the segmented regression approach. Another approach we're using right now is the funnel plot approach. Now, funnel plots are typically used to examine variation in outcomes across various areas. So it could be by LIN, it could be by region, it could be by even smaller areas, but the idea is to understand that variation through scatter plots, through the mean, and through the expected variance. So they're essentially a scatter plot in which the x-axis is the number of people that belong to that area, and the y-axis is the proportion of the outcome experienced in that area. So the nice thing is that it's a function not only of the number of people, but you get a sense of the number of people across region and how that varies over time. So that's the idea. I'll show you an example in a second. But what you can do is not only can you show the observed rates across areas, but you can show the actual mean rate overall and the control limits, which tells you the expected variation. So this can be a very useful visualization tool when we're again looking at area level estimates. So what does this have to do with the pandemic? Well, I'll go through that in a second. In this particular study example, we're going back to our cancer-directed surgeries from the prior cohort, but now we're interested in the risk of ending up in ED within 30 days after surgery. So basically, you've had your surgery, that's your anchor point. What's your probability of going back to ED within 30 days from that? And we wanted to know if there was variation across LINs. I know LINs are being dismantled at this point, but it was still a good indication of regional variation. So, is there variation across LINs? And how does that look like for the pandemic period versus the pre-pandemic period? So has that variation changed? Now, we basically took all the individuals from the cohort I mentioned previously, but now the main exposure is pandemic. Was a surgery done in the pandemic period? Yes versus no. And the other main exposure is the actual LIN of residence at the time of surgery. And the outcome was the risk of ED within 30 days following cancer-directed surgery. So I use this data, apply a funnel plot approach, and this is what a funnel plot looks like. So again, on the x-axis is the number of surgeries. The dot actually represents the LIN. The blue dots represent the LINs during the pre-COVID period, and the red dots represent the LINs, those same LINs during the COVID period. So the x coordinate is the actual number of surgeries that occurred in the LIN, and the y coordinate is the percent of those surgeries that actually ended up in ED. So that's the idea of the funnel plan. You see right off the bat, you see obviously that the red dots, right, are really close to the lower part of the y-axis because the number of surgeries obviously dropped substantially during the pandemic. But if you keep going, you notice some trends. So I pointed out LIN number 2 as an example. So of the 38,000 cancer-directed surgeries that occurred in the pre-pandemic period for this particular LIN, 18.5% of them ended up in an ED visit. So that's how you interpret this plot. Sorry, this particular point. But then this same point is over here during the pandemic period. And you see that of the 3,000 cancer-directed surgeries conducted during the pandemic period, 22.8% of them actually ended up with an ED visit. So lower number of surgeries, but higher proportion ended up in ED. So this is an example of a funnel plot. And the nice thing is that not only is it visually appealing, but you can also see the actual mean rate of the ED visits. So red would be the mean rate, which is higher during the COVID pandemic period, and it's lower during the pre-period. So this is another way to illustrate your data if you're looking for variation in outcome rates across region. And want to compare that to the pre and period pandemic periods. Okay, this last approach, which we are implementing now, is called the mean cumulative function approach. Now, we've set up the actual model, but the data is still being derived. So I've simulated data for this. So the data is not real, but the concept is real. So the mean cumulative function approach. So now we're talking about, this can be used when you have individuals who are followed over time. It doesn't have to be an individual. It could be an area. It could be any unit, but at that level of the unit, the outcome happens repeatedly over time. So in my particular example, we have individuals with cancer, and we're actually interested in the imaging rates, so how many imaging tests they get done throughout a particular trajectory of time. And so because that can happen repeatedly at the level of the unit, here the level of the individual, that falls under something called the recurrent event framework. And the mean cumulative function plot is a very useful plot for illustrating what happens over time under that framework. So essentially, to make this computation, what happens is every point in time, you look at the distribution of the cumulative number of events that you're interested in that have occurred by that time, and then you take that pointwise average and you plot it over time. So that's the idea behind the mean cumulative function plot. Now, what are the outcomes? Well, the outcomes could be, again, they're about repeated measures. So they could be ED visits at the individual level, multiple hospitalizations, imaging services, drug prescriptions, anything that, again, can occur repeatedly over time. And you care about the intensity, how quickly these events are happening. And that may be important during a pandemic period. So we are implementing this approach right now. Here's an example. Again, the example is real, the data is not. So we want to assess the impact of the pandemic on the intensity of imaging tests conducted among patients diagnosed with cancer in Ontario. So patients were diagnosed with cancer between March 15, 2020 and September 15, 2020. So this would be during the pandemic period. And then we had corresponding periods for 2019, 2018, 2017, and you can obviously go back as far as you want, but these are the years that we chose. The exposure is being diagnosed with cancer during the actual pandemic period, and the outcome that we are currently interested in is the intensity of imaging tests. So the times of imaging tests, specifically CT and MRI, 3 months prior to the diagnosis and 6 months after, so within that 9-month window. We basically want to know if the intensity of imaging tests that are being offered or being conducted on patients diagnosed during the pandemic are different compared to that was being done prior to the pandemic. So here's an example, again, with our simulated data of what it could show you. The x-axis here is time since index. So here, this is going to be 3 months before the diagnosis, and we're looking for over 9 months of time. And then the y-axis is the mean number, the mean cumulative number of imaging tests over time. And this is, again, expected at the individual level. So as you can see here, the black represents patients that were diagnosed during the pandemic period. The red represents patients diagnosed during the pre-pandemic period. You could do this for various years of time as well. You could do this for 2020, 2019, 2018. I just showed you 2 years here as a comparison. And basically, at any given time, you can see that the actual mean number of, cumulative number of imaging tests that have been done on those that were diagnosed during the pandemic period is consistently lower. And you can see that by the non-overlapping confidence intervals, especially going further and further out. So again, this can be a really useful plot when you're trying to get a sense of the intensity and the cumulative intensity over time for a particular outcome that happens repeatedly, and how that can vary between 2 periods of time. Now, another plot, and I haven't been able to do this yet, but you can also imagine creating this plot where the y-axis is calendar months. So imagine following people from January, from January 1st of 2020, and then you do the same thing for January 1st, 2019. You'll actually see, if you do that, you'll see this total flattening occurring during the actual pandemic, especially that tight pandemic period when things were closed down. So you would see a flat curve, and then you'll eventually see it being picked up. But it would give you a good sense of how long it looked like that, and then how quickly it picked up again. So that's the idea behind the mean cumulative function. I think that is, oh, no, one more slide. This is just really a reminder for myself as well. How do I go about choosing my statistical approach? Well, the selection of the approach should really be based on the research question you want to answer and on the nature of the available data that you have. So what question do you want to answer, and how do you have the data to actually answer it with the method that you want to use? So that's number one. And number two, I find that as Peter mentioned, like p-values, they can provide us some type of information, but we shouldn't hang our hat on it. Those confidence intervals are really critical, and no matter what, I would really recommend that we focus on these confidence intervals, and we get confidence intervals around the estimates, and not only around these effect estimates that are point estimates, but also in the visual sense to get confidence intervals around those visual estimates like we did for the mean cumulative function. And then the final thing is, these are all statistical tools, but it's up to the person who's implementing these tools to actually find a way to visualize these effect estimates. So highly recommend visualizing the data and visualizing the actual results whenever you can. That's it. Thanks, guys. I believe Therese is next.
Okay, so I will start sharing my screen. Okay. So hopefully everybody can see the screen. Let me see. There we go. So I am the third in a series. So I'm Therese Stukel. I'm a senior scientist at ICS and a professor at IHPME at the University of Toronto. So what I'm showing you, I think we're basically riffing on a theme here, the three of us. We are looking to see, we're presenting methods that would demonstrate what the drop in health services use is during and after the pandemic restrictions. So basically my portion of the study is looking at pediatric healthcare use, and today's talk, I'm just going to look at well child visits, in-person visits, and virtual visits. And what we expected to see happen is that well child visits would decrease to a certain extent, possibly not the ones with vaccination. Okay. And in-person visits would dramatically decrease and virtual visits would dramatically increase. So this is just a slide that we started with to look at, to see, generally what did the trends look like. So pre-COVID, starting around January 2017, just looking at the population trends in well child visits, the trend was generally flat. They didn't go up over time or down, but there were definitely peaks in the fall, November, October, little peaks in January, and this was pretty consistent across time, and then a dramatic drop. Now, when we look at the age-specific well child visits, we basically see the same patterns, except there was some age confounding. In other words, the youngest children, we found peaks in November and January that wasn't totally mirrored in the other trends. So what were we looking to see? Well, basically, the aim was to see what was the drop. And we were also looking to see if the drop changed by age, but that part of the study I'm not getting into today. So what we did was a repeated cross-sectional population-based study of all Ontario children aged 0 to 18 years during and before the pandemic, all the way back to 2017. So we allowed ourselves a very long baseline. The reason we did that is we wanted to capture that trend going all the way back. In case for some of these outcomes, the trend actually was going up, we needed to go back further. So well child visits in person, there's basically a pretty flat trend, but some of the other outcomes, there is a trend. We started the COVID exposure date March 1 because the visits were already starting to drop in March. So the outcome was total ambulatory visits for children, measured at an individual level, or let's say recorded at an individual level by day, aggregated to week, and then further aggregated to the visit count by age group and sex in each week. And this, I'm going to explain why we use this as the numerator for the weekly rates, and the numerator in not only for the plots and the tables, but for our models. The population, which was the denominator, is all Ontario children that met eligibility criteria, OHIP coverage, starting January 1st of each year by age and sex, and that was the denominator for the weekly rates. So one point of explanation here, we did not use the actual weekly denominators. It is true that children enter the province and leave, children are born, children age in, but the changes in the denominator were so slight, and the computational issues of taking account of shifting denominators were so big that we just left them flat. So models that we used a Poisson GEE regression model for clustered count data. So the clustering happened within these strata. In other words, we were measuring visit rates within an age, sex, week, and it turns out there was more than that. There was PSU as well, stratum. So there would be clustering within that stratum, and we didn't believe that it would follow an exact Poisson model where the mean is the variance. So this I'm saying again, the unit of observation, this is what goes directly into the models. It's not the individual number of visits, it's the visits within the age group, sex, and week. The reason we did that was computational simplicity, because otherwise we'd have 3 million children measured over 3.5 years with 52 weeks, and those models simply wouldn't converge. And we know that there might be small variation within children at the same age group, but basically the age-specific effect swamped any individual. The age group effect, the overall age group effect swamped any individual age-specific effect. So the dependent variable was the visit count in each stratum. The offset was the log of that stratum population. We did account for age group and sex. We accounted for a linear time trend in case there was one. In terms of visits, there wasn't, but we put it in as a general marker. And then we had a pre-COVID and post-COVID month indicators. The reason we put the month indicators, I'll go back to this, is we definitely saw peaks and troughs. So each one of every pre-COVID month had its own indicator variable, and every post-COVID month had its own indicator variable. The final piece of this Poisson regression model was we used autoregressive, an autoregressive correlation structure. We used AR12. We could have used AR2. I mean, this is sort of depends on how strongly we thought the correlations were, and our ability for the models to pick it up, just in case, to mop up any monthly surges that were not accounted for by the average monthly effect. So here is the little trick that we use, and this goes back to graduate school, where I remember learning this, and it's a mathematical trick that has actually served me well in several studies. So basically, the models are split into two components, the pre and the post. Why we're doing this is what we're trying to do is we're trying to measure in the pre-period what the trends look like without taking account of the post, because after the pandemic, everything goes haywire. So we want to get a solid measure of the trend before the pandemic. Then what we want to do is measure what happens during the pandemic, the observed visit rates after the pandemic. Then we want to take the baseline trend pre-pandemic, push it forward to the post-pandemic or post-COVID restriction period, and look at the differences. So the little trick that I remember from graduate school is if you zero out everything, if you zero out data in a certain space of your observations and you model the rest, those data will clearly not be influenced, in this case, the baseline coefficients. But if you put in a single indicator variable for each of those data points, you get an independent measure of the baseline, and you get a measure of the post-COVID that maps exactly onto your observed outcome. So we have the two components. Pre-COVID, we have an age-sex trend. Sorry, we have an age-sex effect. We have a pre-COVID linear time trend. For the visits, it was basically flat. We have pre-COVID month indicators. So these go all the way back to January 2017. We had to choose a reference. We used April. And these would pick up more or less the persistent pre-COVID monthly variations. Note that this is the piece that makes the model work. The pre-year, this linear time trend, and the pre-months are coded 0 after March 1st. So basically means the only data that are used to create the baseline model are all the data before March 1st, 2020. So for the post-COVID months, we have an age-sex term. We have post-COVID month indicators, and these are coded as 0 before March 1st. So they do not enter into the pre-COVID baseline model. And in addition, the linear time trend, we do not pick up a linear time trend post-COVID because the baseline linear time trend simply doesn't apply because everything has dropped off a cliff. So then we combine the two sets of coefficients, and this is an exercise simply in linear combination. So I'm going to show you the model for those of you who are mathematically inclined. It's not that difficult. It's not that complicated a model. It's a Poisson model, and we've got the variance GEE terms and the correlation terms. So this is the offset, the population size in the stratum. We've got an age-sex term. These pre-year is simply a linear slope. These are pre-months, which are set to 0 after COVID starts, post-month, which are set to 0 before COVID starts. And then we use the coefficients to figure out what's the relative decrease after versus before. And it's basically computing an observed minus expected. So the observed, I'm just giving the formula for May. So the observed COVID rate after the pandemic started for May was simply the post-May coefficient because these terms zero out. The expected value of this May, had there not been a pandemic and the baseline trends continued, would simply be these two terms. And we push the linear trend into the future and we determine what the pre-month coefficient, the alpha I for May is. So we have a pre-month level for May, and then we have a slope that starts January 1st, 2017, and we push it forward 3 years and 4 months. So what did we get? The plots are a little bit out of sync with the models, and there's a couple of reasons for this, but I'll just show you what we did get. Basically, when we looked at the crude rates in tables, this is for well child visits. This combines virtual visits and in-person visits. They dropped about 40 to 50% overall. And it's about what we find. So this is the ratio of post to pre. In other words, the post-COVID well child visit rate was about 70, 60% of the pre. And this is exactly what we're finding in our models. We have not taken account of age confounding. There was no sex confounding, but we haven't taken account of age confounding, which is why the plots don't exactly correspond. But you do see that there's absolutely no trend. We're doing the same for in-person visits. Here, the in-person visits basically fell off a cliff. the post visits were about 25% of the pre. So they dropped about 75%. And we do see that here. So what we are able to do, though, is measure the effect for every month specifically. So post-COVID March compared to the average of the post-COVID, average of the pre-COVID March, taking account of the linear trends. So I've used this method in other studies. One was looking at the SARS restrictions. Another one was looking at the C. difficile rates after hospital public reporting in Ontario. And basically, when we refined the model, we were able to show that we had an example. I mean, in this particular example, the expected and observed rates were pretty much mirrored each other before reporting. And we were able to show that had the pre-public reporting trends continued, the trend was only upward with monthly variations. So basically, this difference is lives saved due to public reporting. So what can we do with these linear combinations? Or what can we do? What else can we do with linear combinations, and what else can we do with these monthly effects? Well, we can combine the post-month effects, which we did in SARS, if they're flat. So for example, if April to August, we see a drop, a consistent drop in in-person child visits of about 70%, we simply combine them. Another thing we can do, and this is what we did in SARS, we didn't report individual post-month effects, we simply combine them. Another measure that we can look at is one can estimate the months to return to baseline, which is what we did with SARS. So we know what the baseline rate would have been, and we simply follow it out until with some sort of confidence interval, we know that the visit rates return back to where they would have been, and we estimate the months. Another thing we can do with these linear combinations, which we did with C. difficile, we can look at the lives saved due to this public reporting, or the lives lost due to the SARS restrictions. And these were in particular due to surgical volume decreasing, cancellation of elective surgery. So to Peter's point, there is no point computing a p-value or a confidence interval or an estimate when things are so big that you can, you could see it with your bare eye. In this case, virtual visits increased about 55-fold, so 5,500% increase, and you can, basically see it. So let's see, I am stopped sharing my screen. But I think we are now open to questions. So I guess I'm not sure if we have a moderator to look at the chat. So the three of us are now open for questions.
I believe Fang Yun has his hand up. At least that's the one I can see on my screen. Yeah. So yeah. I don't know if you want to unmute yourself, or if you want to, either way, or type your question into the chat. Either way is fine.
Okay, can you hear me?
Yes, we can.
Okay, thank you. Thank you, Peter, Rinku, and Therese. Very great presentation. I have a question to Peter. I wasn't quite clear how you measure your outcome. Was it counts of surgery, a weekly count of surgery, or a daily counts in your Poisson model?
It was a weekly count of surgery, and so the analysis period was a week. Was a week, and so the outcome was how many surgical procedures were conducted during that 1 week period. And then the offset was the number of, essentially the number of people who were alive in Ontario during that week, the number of people who were at risk for surgery or eligible for surgery.
Okay, it's a weekly count. So then you have only 3 points for pandemic or post-pandemic, because
in that example, yes. So in David's study was a study about the early effects of COVID. And so it was conducted relatively soon after the CIHI data was available for that time period. If one were doing the study today, one would have 16 to 20 weeks post-pandemic or during the pandemic. So it would essentially reflect what was available when the study was being conducted.
Yeah, okay. Yeah, that's my concern, that because it only capture 3 weeks, then it wouldn't be able to capture the uptake of the trends after.
No, exactly. David's study was a very early study, and which has been published already. A study that was being designed today would look at both the decline in surgical use, as well as, I assume, the gradual recovery during the opening up phase.
Okay, thank you.
So I'm just looking at the chat. I think some folks.
I see one that's.
Well, I was going to say, I think some folks are asking about sharing presentation slides, and just to let everybody know, I believe this session is being recorded, and the link will actually become available later. So I think there was a few questions on that, and I believe Samantha was next on the chat, at least. That's what I see. I don't know, Peter, if you see the same thing, but I believe Samantha's asking about what difference would you consider enough to see with your eyes that you wouldn't require modeling? I'll let Therese answer that, because I know she had mentioned that during her talk. Oh, you're muted, Therese.
Yeah. So I don't think there's any magic number. I think virtual visits, I mean, you could actually say that for every one of the 3 outcomes that I examined, you didn't need statistics. I mean, because the population, the sample size, let's say the population was all children in Ontario. There are 3 million children. So if you start to see even a 10% decrease, it's real. I think both of us, I mean, I don't think any of us would go into a statistical journal saying we saw a 10% decrease, we didn't bother modeling it because we know everybody will understand that must be real. I think what we're trying to show you are 3 different ways of modeling drops or differences or changes that apply to a lot of situations. So in this case, yes, the rates dropped off a cliff, but in many cases, you'll see something like in our C difficile example, we showed, I think I can't remember how big the differences were, but using our models, we were able to actually measure lives saved. And I think that's what people wanted to know. So it's basically what we're trying to demonstrate are how do you model decreases? In the case of SARS, we compared to Ottawa, to London, and to the circum-GTA, where there were small differences, but not the drop off a cliff like we saw in GTA, but we did need modeling to say there were minor changes, nothing compared to GTA. I mean, that's a long-winded answer. So Jermaine?
Hi, it's Jimmy, and thank you very much for 3 presenters' presentation, cover many statistical method. My question is that, we also sometimes using the time series analysis, say Riemann model. How would you, my question goes to 3 presenters, how would you evaluate a Riemann model versus the Poisson model or funnel plot? What do you suggest?
So I get this question a lot, and I actually would like Peter and Rinku to chime in. So I'm going to say that these are all, the time series models are models that we all learned in graduate school. I have not used a time series model since that time. The reason is that these Poisson regression models or any of these longitudinal data analysis models, like logistic regression, linear count data, are able to model individual behavior over time and take account of correlations, take account of time trends, take account of individual risk factors. So you get a much finer model than you would ever get with an ARIMA model, for an autoregressive moving average model. These ARIMA models are typically used by economists to look at long-term trends in the economy and labor markets and interest rates. And they usually have as input very gross markers of, say, labor market activity or financial activity. We could use them, but I think you would simply lose a lot of the signal. So I'm not sure what Peter and Rinku think about this, but that would be my take on it.
Okay, thank you.
Yeah, no, I agree. I also don't use these approaches often. I'm talking about time series approaches. And I think it's for that same reason. We have such granular data. And in most of, at least the cases I work with, these data are at the individual level. And if we're interested in adjusting for individual level characteristics and understanding the trend that's arising from data at the individual level, it's just not as appealing to me. I can see that if we had simply regional data and we're looking at trends over time, we're not interested in those adjustments, then it would be fine for me to implement. But in general, I guess based on the richness of the data at ICS, it's not something I kind of gravitate towards. That being said, you should get really similar results. And if you're not, it's probably not a good thing, but it's not that you can't use these methods. You certainly can use ARIMA or any type of time series method for a lot of the approaches we're suggesting.
Yeah, I'm going to say I'm not sure you get the same results just because you couldn't set up the data the same way. I mean, the ARIMA models are basically looking at clusters over time. And I'm not sure how you'd have to look at the average age and the average sex and the average diabetes rate and the average.
It's true, but like, for example,
it would require a lot of work.
It's true, but in the segmented regression approach that I was going through, like in that particular case, I think it may be applicable because the data was at the level of the week and we're looking at volume trends over time, right? So I can imagine something that is an ARIMA model being implemented there, and I would expect that drop at the pandemic, it better be quite similar, right? If I'm getting something really different, that's a problem. But again, I'm with you, Therese, in terms of the granularity. I don't think it's worthwhile with the data that we have some of the time anyway. Peter, I don't know if you have anything to add.
I would, two things. So one is that this is speculation. I would speculate that the ARIMA model, so if we had weekly data, like was presented in David's study or your study, if we had weekly data on rates of use, I would speculate that the ARIMA approach would need a much longer historical trend to model seasonality and the historical trend in order to make projections. That's just speculation. The other comment would be around transparency, in that the methods that each of us presented, Rinku, Therese, and myself, that my speculation is that minor modifications in what we did would lead to similar results. So if in David's paper, if instead of just using a crude Poisson model, he had done age, sex, stratified cell counts, he would have come up with the same result. If Rinku's analysis had been slightly different, she would have come up with comparable results, and the same with Therese. I find, and this may reflect more my lack of experience with ARIMA models, is that I find them to be a bit more of a black box, in that there's many more parameters that need to be tuned and chosen and selected, and that the selection of those parameters may have more of an influence on the subsequent results. And that I find that it can be harder to communicate, that one can say I fit in a ARIMA model, but the details are omitted, which doesn't allow someone to replicate what you did. Whereas the methods that we've presented, once you've provided a statistical model, then people can replicate what you did.
So I'm just going back to the chat. I believe Lucas had a question, and this is for you, Peter. Can we combine more than 1 week to compute the relative rates? For example, combining the 3 post-pandemic weeks using only 1 relative rate.
Yeah, I think you can do whatever makes sense in your context. That a week, for something like surgery, where there's a fair number for surgery, for physician visits, for diagnostic procedures where there's a large volume on a weekly basis, there's no reason why you can't do it weekly. If you were looking at something where there was at a service or procedure that was rarer, you may want to aggregate to the month or 4-week periods in order to have a little bit more stability. You would probably lose some of the immediate pandemic effect. But I think you need to find a balance between finely graded time points and point estimates that are estimated with reasonable accuracy. But yes, there's no reason why it has to be 1 week.
Yeah, I'm going to chime in and say, I think my example, illustrates this. We had 3 million children measured weekly over 3.5 years, tons of granularity, but completely hopeless in terms of getting the models to converge. So that's speaking to Peter's balance, is we had to aggregate in order to get models to run. And we knew that there'd be, the basic trends would be the same.
I believe I see Jessica's hand up. Jessica, did you want to unmute yourself? Yes, thank you.
Thank you so much. These talks were so great. I really enjoyed them. Most of the methods appear to be looking at relative rates or changes from baseline pre-pandemic. My question is about, what are your thoughts on the best approach to quantify absolute differences to be able to quantify patient backlog? So looking at the potential number of patients that have been undiagnosed in the population, so the number of patients that accumulate over time. I look at my patient population are individuals with rheumatic diseases, and I'm worried that new consultation rates are declining dramatically. And while we can't measure wait times for these individuals in the population, I'd like to be able to look at quantifying the new consultation rates and looking at the volume, declining over time, but then also, trying to identify or quantify the number who have been not seen, if that's kind of clear.
Yeah, it is. So I can try to answer this first, or at least address part of it. In the segmented regression approach that I had gone through for looking at cancer-directed surgeries. So you can, based on how you parameterize that regression model, as we did, we actually captured the absolute value of the average number, so the expected number of surgeries that occurred once the pandemic started. So that is that absolute shift that you could actually get a measure of. So that value that you saw, if you go back to the slides, so I can't share it right now, but basically that's telling you what was the actual mean number of surgeries at the very beginning. So in 2018, what did it drop down to March 15, 2020 at the start of the pandemic? So that is that absolute difference. And from there, of course, you can get relative rates as well. But so there is ways to parameterize your model so you can actually capture that absolute change. Now, I think you're also talking about capturing the expected absolute value over time, right, as well. And that can come from your model. So you could use your prior data to get expected results in the future, but again, in absolute terms. Most of what we presented is in relative terms, but it would be achievable, but again, it's about how you parameterize your model. I don't know if that made sense. Peter, Therese, any other comments?
Yeah, I can comment. The linear combinations that I use are actually taking the expected value in the future of what you would have expected if there were no restrictions. So that would be the absolute number. We can measure that using the models. In terms of wait times, that's a really difficult question. So we did do some of this modeling in the SARS paper, the SARS descriptive paper. where we were looking at elective surgeries, and we saw that they dropped by about, I don't know, 50% in the GTA. Taking that number is a little bit misleading because it's not clear that all those people that needed cardiac surgery are going to survive to the end of the pandemic. It's not clear also whether people showed up. People stayed at home. It's not clear what happened to them. So yes, you can only model what you have. So you can estimate the expected. Modeling a wait list is much trickier. There's just many things that we don't have in our data to be able to do it. So any other questions?
I see one in the chat from Jacob.
Okay.
Do you have thoughts about how your methods compare to using statistical process control charts to answer simple questions about whether follow-up differs from baseline, whether control is reestablished and at what level? There seems to be a lot of overlap between SPC and several of the approaches you presented. That's a very interesting suggestion. So for those who are unfamiliar with it, statistical process control can simply be thought of as, it grew out of industrial statistics where they were looking at the number of defects in manufacturing processes, and they reported these on a daily or weekly basis on an ongoing longitudinal basis. And then they would essentially say, from the long-term average, what is the range, like, the mean number of defects plus or minus 2 standard deviations or 3 standard deviations, and then it simply had a horizontal line running along this way. I think here's the upper and lower limit for the number of defects. And then when a weekly number of defects surpassed those quality control limits, then you said that the process was broken, something was wrong and needed to be investigated. No, that you could do this, that if you could establish, estimate compute the weekly number of surgical procedures or diagnostic tests, and find what the long-term standard deviation of those was, and then plot those, and then see, when did they deviate from that, and when did they return to control. So I think that's a really interesting idea. The only limitation in moving, so in industrial quality control, one wouldn't expect there to be any seasonality, so to speak, that the number of defects on your chip or on your automobile should be the same in January as it should be in March and April and so on. Whereas there is going to be a natural, depending on your context, there will be some natural variation in terms of health services use. We already saw from my figure that the surgeons all go on March break, for instance. And so that variation would be incorporated into your standard deviation. So there may be some seasonality that would not be, that you would want to be able to account for, but I think it's an interesting idea.
I believe the next question is from Rob. Rob is asking about, for longer time series, you always hear about autocorrelation and seasonality. How do your proposed methods handle the potential threats to validity?
I think I'll answer that question. I think we put in terms for seasonality and autocorrelation. It's not that difficult if you have a longitudinal, if you have longitudinal data. We have counts measured over time. So we just put in the month trends, and that seemed to take account of most of the seasonality. And we threw in an autocorrelation just because there are spikes that sort of spill over from one week to the next, and the autocorrelation would mop that up.
Yeah, and you could do the same thing under the segmented regression methods. You can, because it's still under the Poisson or even the GE Poisson framework, so you can account for that autocorrelation. Probably, I'm not sure how refined it is when you account for it under an ARIMA model. But the other thing that, at least for the cancer-directed surgeries, I mean, it was so stable, as you saw from 2018 up to the pandemic, that there wasn't much to account for. I mean, that relative increase was essentially at 1. So there are some cases where it's important. There are some cases where it's not as critical. Just looking through the chat. I hope I didn't miss anything.
So I guess I will ask a question to the audience. Does anybody have a method that we missed? Something that something that might be interesting to bring up to the group? I mean, we have somebody mentioned time series models. Somebody mentioned statistical process controls. I've been reviewing a lot of papers in this area, or some papers in this area recently, but there's been a lot of them. And some of them are very basic. They go to last March, this March, and do a t-test. I think we can do better than that.
Oh, Therese,
someone has just... Go ahead.
I think someone is asking Therese if she used autoregressive model with lag terms.
Yes, we put in an autoregressive correlation structure so that from 1 week to the next, the visit counts would be correlated. So if it's high in a certain month, it's going to be high most of that month, but it's also going to be high the last week of the month before and the first week of the month after. So what we wanted to do was, I mean, it's based on the software. I mean, you can put in an autocorrelation that goes back as far as you want. So an AR1 would say any 2 pairs, one after the other, are correlated. AR2 means there's a correlation between a certain week and 2 weeks prior, 2 weeks post, but it's attenuated and you can go back and forth. You know, as far as the software will handle. So difference in difference approaches. So maybe Rinku, probably like that's well, maybe not. Segmented regression is closest to a difference in diff and diff.
It's true, like a difference in difference approach. For those on the call who are not aware, it's basically when you have people who are exposed, people who are controls, you're trying to understand the difference between some outcome between these 2 groups, but compared to 2 different time periods. So basically for the exposed, you'd have in this case, post-pandemic data, pre-pandemic data, and then for the control, you'd have the same kind of thing. So you'd want to understand the difference in the exposed between post and pre, and compare that to the control post and pre. So that's what a difference in difference is. But the actual corresponding regression model to that is actually some type of segmented regression where you have interaction terms. So if you have in your segmented regression, you have your main exposure being exposed control, you have your time period being post and pre, that interaction would actually give you a sense of that difference in difference. So that's really what you can actually show that these are very, very similar quantities. So I hope that helps. So it is kind of a difference in difference approach, except using a regression, you could also make a lot of adjustments. So that's why we presented it that way.
Yeah, I'm going to jump in and say, I've had these conversations with people before, and I think as statisticians, we tend to label things less and just lay out the model.
Yeah.
You lay out the math.
Yeah.
You can call it segmented regression. You can call it a time series. You can call it longitudinal, data analysis. We're less fixated on what you actually call it and more about what should the structure of the model be? What do you expect? What do you see in the data? How are we going to model this? Sometimes we throw in like an instantaneous slope change or an instantaneous intercept change. Sometimes we let the change occur more smoothly. So again, I see a question about regression discontinuity design. That is a segmented regression. So you call it RDD, you call it segmented regression. Diff and diff could follow the same model depending if you let something abrupt happen at a certain point. It depends on what you're trying to model and how you actually, it depends on what you're trying to model, what your data looks like, and how you want to express the findings. Sometimes you just want one number, everything changed by X, but usually it's a little bit more nuanced than that. It changed by 5% in the first month, but it continued to change by 5%, and then it flattened after 3 months. I mean, it really depends on what you're trying to do.
I think there's a bit of a difference with regression discontinuity design, in the sense that there you're trying to see what's the effect of a discrete intervention in time. So a change in insurance policy, a publication of a landmark RCT, how did a single event in time have an effect upon outcomes? Whereas the pandemic is whereas there was there's multiple phases of it. We can't really say what's the effect of the pandemic as a discrete event. Rather, it's a continuous, ongoing event, whose and the reaction of the healthcare system to it changes over time. And so, I'm not sure I would use a regression discontinuity design, because the pandemic is not a discrete point in time that has the same effect on everything. Its effect is not constant over time, but rather it's going to have an effect that varies over time.
And so pandemic restrictions are a discrete event over time. I mean, they just came down on March 13th.
Yes, but then
everything afterwards, yeah.
Right. Like what I've seen regression discontinuity design it tends to be when a trial was published, when there was a change in the States, when there was a change in insurance reimbursement policy, when something happened and everything was the same everything changed, but then was the same going forward, as opposed to a pandemic, which is a evolving situation, and the regulations and rules and response to the healthcare system were constantly changing over time. But there was a question before that about software. I think that everything that we've discussed today is relatively generic, and you should be able to implement it in any major statistical package. SAS, R, Stata. You'd be able to do everything today, I'm guessing, in one of those three languages. At least my method you can, and I'm sure Rinku, segmented regression you can, and Therese's
for sure. I don't know about the mean cumulative function for sure in SAS and R. I'm not sure about Stata, at least to get those visualization of the MCF plot over time. But I used R to do that, and I'm for sure SAS has that code available as well.
So I'm going to thank everybody for attending the session, and certainly if you have more questions, we are here, we're free to answer them.
Thanks, everyone.